will be joining soon. Or someone from the GI unit, please remind her to join. And how many total slides you have? Like last time there were 110 slides. It was impossible to finish. How many slides you all have total?
Sir, I have around 60 slides. Sir. 50,
okay. I think that makes sense. Because to present 110 slides, you have to finish at the speed of 30 per second or even faster than that, which is almost impossible. Okay. So when you make a presentation, it should be there. So main thing is discussion of the case. And of course, then you also show, but it should not happen that I think you can start now, Shakti.
Yes. Good morning, everyone. I would be presenting my ward rounds topic today. To start off with, I have my case capsule. It's a 68.
So who all are with you in the team today? Just say the names.
In my first year is Dr. Rahat Malhotra, me, and Shaktivel Mani. Then Prithvijit is JR3 and Dr. Akansha is the senior resident in our team. So to start with our case involves a 68-year-old gentleman who's a resident of Patna, Bihar, who's a farmer by occupation and with a history of diabetes and hypertension for the past 15 years. He presented to us with complaints of blood-stained mucus discharge while passing stools for the past 6 months, which was also associated with constipation for the past 2 months and weight loss for the past 2 months. On the history of presenting illness, he was apparently normal 6 months. Can you hear me now?
Hello? Yes, we can hear you now. Yeah.
Okay. The slides are not moving. Oh. It's not moving. So 1 minute.
I thought the problem was at my end, so I, left and again rejoined.
I'll join again. The network went, sir. 1 minute.
What happened? You are trying for your slide share?
Yes, sir. Can you hear me now? Is
Yes.
my screen visible? So coming back to the case capsule. So the 68-year-old gentleman who was a resident of Patna, Bihar, and was a farmer by occupation with a history of hypertension and diabetes for the past 15 years. He presented to us with complaints of blood-stained mucus discharge while passing stools for the past 6 months, along with constipation and weight loss for the past 2 months. He was apparently normal 6 months ago when he started to realize he had presence of blood-stained mucus discharge while passing stool. It was associated with his altered bowel habits. This is also associated with his complaints of weight loss for the past 2 months. In the negative history, he had no history of obstipation, unable to pass stools or gas, no history of fecal incontinence, no history of urinary complaints, no history of jaundice, no history of usage of alternative medicine, and no history of steroid usage. For his medical history, he's on metformin for diabetes and amlodipine for hypertension, and there is no previous surgical history of any surgeries. Personal history is usage of chewable tobacco in the form of gutka for the past 20 years. There's no history of high-risk sexual behavior. And family history, no family history of any malignancy. Since he's a farmer who has completed primary school and belongs to a lower socioeconomic class. On general examination, he was moderately well built and nourished. His weight was 57, 164, and BMI was 21. On general examination, he was a good Karnofsky performance score with stable vitals, and pallor was present. On systemic examination, per abdomen, there's soft, non-tender, there's no palpable organomegaly, and there's no palpable nodes in bilateral groins. In digital rectal examination, which was done in Sims position, which patient examined in left lateral position, with left knee slightly tilted and right knee flexed. On inspection in the perineal region, we could cauliflower-like growth was seen protruding from the anal verge, approximately 5 cross 2 centimeters in size, extending up to 1 centimeter laterally into the perianal skin region. There were no visible skin tags or external hemorrhoids. On palpation, the sphincter tone was normal. There was a hard ulceroproliferative lesion seen arising from the anal verge from 3 o'clock to 9 o'clock position approximately. It is extending superiorly into the anal canal up to 6 centimeters from the anal verge and laterally extending into the perianal skin approximately around 2 centimeters. There was a blood tinge PR on examination. This is a representative picture of showing the clock position of how approximately it can be from 3 to 9 o'clock position. And we've done a clinical diagram representing the same. On systemic examination, the CVS, RS, and CNS were normal. Based on the findings of my history, I would keep my differential diagnosis of prolapsed external hemorrhoids, anogenital warts, a rectal polyp, CA anal canal, or perianal carcinoma. Based on the above history and clinical findings, I would consider my provisional working diagnosis as CA anal canal, CT3N0M0. For the above complaints, he was decided to evaluate it. On routine investigations, his hemoglobin was 10.5. Blood counts were normal. Creatinine was 0.65. His viral markers were non-reactive. A biopsy was taken from that site, which was a moderately differentiated squamous cell carcinoma, which was negative P16 negative.
What kind of biopsy was that?
So it was a punch biopsy.
Yeah, carry on.
Diagnostic evaluation, an MRI pelvis was done to understand the local tumor description. As you can see, it is a T2 sagittal image of the patient with a hyperintense lesion involving the anal canal and the lower rectum around from 2 to 10 o'clock position, and craniocaudally the tumor length was around 7.4 centimeters, and sphincter involvement, internal sphincter, intersphincter space, and external sphincter was involved. Levator ani was abutted without infiltration on both sides. This is the image of the tumor, including the anal canal, lower rectum. The tumor extended into the lower rectum, but the planes of the septum and all are still clear. And this is the coronal view. As you can see, it is extending into the ischiorectal space regions, and the levator ani muscle can still be seen darkened on the right side. It is slightly thinned out on the other side. It was abutted but not infiltrated.
So was there concordance or discordance between your clinical findings and MRI?
So there were similarities, sir. Like as per the MRI, they reported 2 to 10 o'clock position. DRE showed 3 to 9. The craniocaudal, according to the MRI, was 7.4 centimeters. Ours was 6 centimeters,
Okay.
which approximately matches with our DRE findings.
Oh, so 2 to 10, you were talking about the clock position, not
Yes, sir.
from starting from 2 centimeter. Okay.
No, 2 to 10.
Okay. I thought, okay. Yeah, sure. Carry on.
So in this one, you can clearly see the levator ani muscle on this side. It's abutted but not clearly infiltrating in the corona in this way. Similar images of the levator ani muscle. So for the node, and there were nodes involvement was seen. Few mesorectal nodes, at least 7 to 8 were seen. Largest was 7 cross 7 mm, and bilateral external left and left internal iliac and left obturator nodes were seen. The left external iliac was the largest, around 1.7 into 1.3 centimeters, and indeterminate inguinal nodes were present, but they were but on bilateral USG groin, they appeared reactive. We had stage N1C, and for metastatic, a CT thorax was done, which was no evidence of any lung metastasis. So my final diagnosis based on this was CA anal canal, CT3, CN1M0, MDSCC, P16 negative. I'm staging it as T3 because the tumor is 5 centimeters and more than 5 centimeters in size, and it is not invading into any other organ, so it is not T4, and it is N1C in view of presence of metastasis in external iliac nodes with any N1A nodes. So N1A nodes for us were mesorectal nodes and the internal iliac nodes, and there were no distant metastasis. So it is CT3, CN1C, MDSCC, P16 negative. So coming to our treatment plan, our plan for this patient was definitive radiotherapy along with concurrent chemotherapy. In radiotherapy, our target volumes of the gross disease and the draining lymph nodes. Our dose fractionation we've taken is 45 gray in 25 fraction at 1.8 gray per fraction, followed by boost to primary to a dose of 15 gray in 16 fraction using IMRT technique. And for chemotherapy, it will be oral capecitabine along with mitomycin C protocol. Oral capecitabine is given at 875 mg per meter square twice daily along with radiotherapy for 5 days, and bolus mitomycin C is given 12 mg per meter square on day 12 mg per meter square on day 1. So EBRT counseling, since this patient is going to be treated in the pelvic region, we need to explain him about the probable side effects of short-term as well as long-term effects. Plus the duration of treatment, which is around 5 to 6 weeks, where the patient has to come daily for treatment and has to be daily preservation. And in terms of young adults or young adults, importance to be given to the fertility preservation, and for premenopausal ladies, the chance of premature menopause is also there. So fertility preservation options should be explained to these patients prior to the start of any treatment. During the treatment, they need to ensure, since we would be treating the groin sides along the nose, they should be wearing loose-fitting cotton clothes so that there is good aeration in those areas. And maintenance of proper self-hygiene is important. By self-hygiene, we mean that the patient should have a regular bath, but at the same time, he should not be around putting strong irritants on the skin, especially in the radiation side, such as he should not be putting strong deodorants, perfumes, or applying any kind of ointment or anything without consultation of the doctor. And since we will also be expecting GI and GU toxicities, we expect him to take a home cooked food, light diet, so that he ensures that he is not causing too much irritation to his rectal mucosa. And fluid intake should be adequate, 3 to 4 liters, so that he is well hydrated during the treatment, and also it will help us in sparing the bowel. And during treatment, we can prescribe topical steroids, which he can apply over the radiation site for symptomatic relief. So simulation, we simulated this patient in a supine position with a bladder protocol of 500 ml in 30 minutes. We asked the patient to void urine and then drink 500 ml of water over 5 to 10 minutes and hold it for 30 minutes. And then a simulation scan is taken. And we keep a fiducial marker at the anal wall so as to identify it on a CT scan. And the external fiducials we keep at the pubic symphysis. We take supine is relatively more comfortable, more reproducible, and there's lesser interfraction variability. Whereas in prone, it is sometimes uncomfortable for the patients. And secondly, if they have a colostomy bag and there's a divergent stoma, it becomes even more uncomfortable. Then coming to the target volume delineation, my clinical target volume would include the gross primary disease enlarged lymph nodes, including the mesorectal space, perirectal, mesorectal space, the lateral lymphatic groups, which is the internal iliac and the obturator group of lymph nodes, external iliac, and the superficial inguinal lymph nodes. So starting my contour from the bifurcation of the common iliac into internal and external iliac. So going downwards, I also included the external iliac nodes with, you can see there's a large external iliac node present, which has been included in the contour. And along with the inguinal nodes, as well as the primary tumor in the lower rectum and the anal canal. And we placed a fiducial marker. And as you can see, the disease is including at the level of the anal verge, and it is also protruding outside. So this patient has completed phase 1 EBRT to the primary and draining lymph nodes using 6 MV photons. We treated him IMRT technique 45 and 25 fraction. At the completion of phase 1, there was a residual primary disease 4 to 7 from 4 to 7 o'clock position, 1 centimeter from anal verge up to 3 centimeters. It was a good response accordingly. And the RTOG toxicity, he had grade 2 patchy moist disformation over the gluteal region. And lower GI was grade 1 and GU, genitourinary, was grade 1 toxicity. Just wanted to show you the 95% dose coverage. We covered the nodes with the presacral space along with the inguinal nodes, including the boost to the nodal region. So after phase 1, since the patient had good had response and was clinically stable, and we planned for and skin reactions are within tolerable, phase 2 EBRT was given to the dose of 15 gray in 6 fractions to the residual primary disease and left external iliac nodes along with concurrent chemotherapy, which was oral capecitabine. The bladder protocol remained the same, and simulation position was supine arms overhead, pillow knee rest. In phase 2, our target volumes were reduced. As you can see, we included only the primary GTV as well as the nodes. It can be seen in this sagittal view. It only included the primary tumor as well as the nodal region. There were no prophylactic nodal irradiation. So he concluded EBRT to 45 and 25, followed by a boost to the primary tumor and left external iliac nodes to a dose of 15 gray in 6 fraction. Once daily using IMRT along with concurrent chemotherapy. His treatment time was 47 days. His toxicity skin grade 2, there was patchy moist disformation over the perianal region. GI was grade 1, GU was grade 1. And we had advised him skin care. By skin care advice at conclusion is whatever precautions he was following during treatment has to be followed for another 4 to 6 weeks, because the chances of these reactions increasing over time is very crucial, because these patients already have moist disformation in the perianal region during radiotherapy. And we've asked the patient to follow up after 6 weeks for clinical examination locally and a CT abdomen and pelvis to assess the nodal response. So summarize my case. He's a 68-year-old gentleman with history of gutka usage and hypertensive and diabetes, presented with complaint blood-stained discharge and while passing stool, and was evaluated and diagnosed as CA anal canal, CT3, CN1C, MDSCC, P16 negative, treated with definitive EBRT along with concurrent chemotherapy. On follow-up, for first 6 weeks, he was doing well. There's minimal irregularity felt 1 centimeter from the anal verge. On a CT abdomen pelvis was done to assess the nodal response. There was a decrease in the nodal mass, and there was no evidence of distant mets. Since then, the patient has been kept on a 3-monthly follow-up. Now coming to the discussion part.
Just hold on. Before we come to the discussion for this case, so you mentioned few things during history. You said high risk sexual behavior. So what do you mean by that, and what questions would you ask for that?
So for this patient, we asking, is he married? Is he unmarried? After asking, based on his marital history, does he have kids or doesn't he have kids? After that, based on the kind of sexual, because has he had multiple sexual partners? That is another we asked, and post that any history of other forms of sexual intercourse, like anal intercourse, and this way.
Okay. See, most of us, or I would say none of us, are trained to take sexual history. In some of the departments, specialization like skin and venereal disease, they would take a direct history, but none of us are trained. So you should know, if not all cancers, but some of the sexually transmitted. So HPV is sexually transmitted. So for that, you should know how to ask the question. Okay. So the other question is, who's your JR3 right now, the exam going batch? Prithwijit. Prithwijit, are
Yes,
you
sir.
there?
Yes, sir.
So before when you were doing counseling for RT, CT-RT, the patient's son who lives in Singapore, who has come and asked, Doctor, are you sure that surgery is not needed for my father? We want him to survive. That is most important. And we want him to live and do whatever is required for him. He was afraid of surgery, but if you think that surgery is best for him, we will convince him for the same. Okay, we will try to convince him. So, how will you answer that question?
Sir, for
And
uh,
patient is also sitting there in front of him. His son is asking this question. So, what? How will you answer?
sir, the practice for surgery
So
in
now
case of
you are
CA.
talking to the son who is very concerned, who's a young fellow who lives in Singapore, who has come. And so you explain to him. You talk to the son about his father, and the father is also sitting next to him.
Sir, I will explain him regarding the what is the
You
role of
talk,
CTR.
you are just imagine in front of you, the patient's son is sitting. You have known. So this is a case of it was a T3N1 anal cancer, moderately differentiated squamous carcinoma. You
Yes, sir.
have a finding. So you talk to him. Please just gather your thoughts. Just think for a minute. So while in the meanwhile, I will ask other questions to maybe Shaktivel. So Shaktivel, is there any utility of ultrasound in these cases? Does it add any value, ultrasound?
So for ultrasound for the groin region can be done, sir. For mainly the inguinal nodes, they're more sensitive and specific to pick up inguinal nodes in that side. And if there is a
So what
node
are
which
the
can,
issues? What are the issues, clinico-radiological issues in evaluating the inguinal nodes? Tell me.
so clinically, there could be, while palpation, it would depend upon the skill of the individual who's palpating as well, whether whether by chance he's able to pick up nodes or not pick up nodes.
So that will happen only in obese individuals. I mean, otherwise, in a thin individual who is not doesn't have much of fat, you will not miss inguinal nodes. So what else? What are the specific issues of inguinal node assessment? Rather than not feeling enlarged inguinal node, what is the main issue? Come on, you know that answer. Come on, don't just think. That problem can arise with assessment of any lymph node, peripheral node, but in inguinal node, it is particular, and in tropical countries, in low and middle income tropical countries, this problem is even more in assessment of inguinal nodes.
There could be some there could be some lymphedema,
What?
elephantiasis.
Elephantiasis is very rare. How many patients you have seen of elephantiasis? They're only in the textbooks now. You very rarely you see elephantiasis. So it does happen, but not. So what is the
Fungal infection.
now? Don't be specific. They
Sir,
could be reactive due to so many things. So why in
Fungal
lower
infection, tinea.
there is a patient who's living all his life who was born and brought up in England, as to a patient who was born and brought up in a village in India. So what are the issues in inguinal load assessment in these two cases? Both have CA anal canal. Or say penile cancer. In penile cancer, this is very common. I think Prithwijit, you first answer that question before you answer your question.
sir, for him, the treatment is CTRT because
No.
surgery.
Abhi, CT, I tell you were thinking of your answer. So,
Okay.
Akanksha, you are the senior resident for this group. Are you there?
Yes, sir.
Question to me, please. Just tell them what is the issue in inguinal node assessment. I think you all have okay. Anyway, I think I'll just finish this. Someone has already put. So in tropical countries and lower socioeconomic status countries, people walk barefoot very commonly. They are more prone to injuries, infection. It is it sweats and the climate. It's a hot, humid climate. So there are much higher chances of infection in the lower extremities, especially in the foot region. So reactive lymphadenitis is very common. So this becomes an issue when this is actually the primary drainage site, so which is a penile cancer or anal or perianal region. Okay, especially if it's a perianal region. So that you have to. Now, Prithvijit, so you have to answer the son who's asking father sitting next to his father, doctor, do whatever is best. Are you sure surgery is not required for my father? I know he's scared, but we will convince him if you feel that that is the best for him. Please answer his son.
Sir, for him, the
No,
treatment
no,
is
you're
obvious.
talking to his son, not.
Yes. Yeah, the patient is having CNL canal for which the treatment is actually CTRT. Surgery is abandoned very earlier. It was previously in 1970s the surgery was done. But for him, we can actually CTRT will have a higher survival and higher control compared to the surgery, because surgery will need removal of the rectum that ultimately leads to the colostomy, permanent colostomy, which is not needed for any patient. And for we can actually avoid that thing and give CTRT with better outcome. And surgery was abandoned, and it is the recent standard of care everywhere in the world. So for him, obviously the management is CTRT, not the surgery. And a surgery would be appropriate if he developed some in the future, if he developed recurrence in follow-up cases. Otherwise, I would prefer CTRT, obviously, because it is the current standard of care.
Okay, so when you talk to families and patients, you have to say, so you have to write. See, first of all, anyone asked a question. So you don't have to say, Ravish, it's a stupid question. You have to say, well, you are right in asking this question, why we have not advised surgery for him. Uh, Once upon a time, surgery was the standard treatment for all patients like your father. If when they came, we used to do a big operation where the cancer was removed and a permanent bag was put, a colostomy bag was put. But in the last 30, 40 years, we have seen that patients for whom we don't do surgery and we give radiation with a proper technique along with chemotherapy, their chances of cure and chances of avoiding a colostomy bag is very high. So now all patients with anal canal of the stage which your father has, we treat with chemotherapy and radiotherapy. And in case the cancer has not been eradicated or it comes back, then we resort to this surgery. So don't worry, this is a standard method of treatment, what we are advising, and it's not just because your father would be scared of the big operation. Okay, so that is how you answer the question. Okay, carry on. Let's go to the discussion part. And while examination, you should also comment that there were no infection in the draining area, like in the feet or in the lower extremities or lower abdominal wall. Okay, that also you have to mention. If you find there many scratch marks or infection, then you can look at the feet, you would know. These days, fortunately, people who walk barefoot has become less. Even in villages and in poor people, they also wear slippers and footwear. Earlier, many people used to walk without footwear. Carry on.
Now coming to the discussion. Discussion part, to start off with, I'll briefly
Has Reena, have you joined, Reena? I don't know whether Reena.
Yes, sir, I'm there.
Okay.
Yeah.
Okay.
Yeah.
Okay.
Okay.
So you can come in whenever you want to,
Okay, sir.
So that how you answer the patient son, is that the way you would answer how I answered Reena, or would you answer in many differently?
So, sir, yeah, same. We have to say that now CTRT is a standard of care and best advantage is organ preservation in more than 75 or 80% of the cases. So
So
otherwise it will be
let me just, I think, ask the third year, Prithvijit, but are there some cases where you may not want to do so? When you say, Reena said organ preservation, what else you want to preserve along with organ? So what else you want to preserve? Organ and
Sphincter. Sorry,
organ and function. Okay.
function. Yes, sir.
So if suppose the patient had the sphincter tone was lost and patient had incontinence, would that influence your management decision or may influence?
Sir, for this patient, for any patient or for anal canal, if the sphincter is normal or sphincter function is preserved or not, I would still go ahead with CTRT, because we can actually spare the rectosigmoid part, because the surgery will be very extensive and the patient will have colostomy, which will.
So which is better, patient having an incontinence and wearing diapers the whole day, or patient having a colostomy bag? See, it's a philosophical question, but would you at least discuss that or think about that, or it's just
No,
that it has to be
sir,
CPRT, whether patient is incontinent, fecal incontinent, all throughout?
I'll discuss about this. If the patient, the sphincter is completely involved and completely functionless, then I will discuss about the
So see, this is a
future.
very difficult. I mean, no one really knows the answer. It is. I don't know what is it. Our GI unit practice now. I mean, these cases fortunately are very rare. But Reena, when do you
yeah.
see such cases?
Yeah, so in our JC, we counsel the patient. We do go ahead with stoma and then complete CTRT. The reason we go ahead with CTRT is anyway we need reduction in size and extent of the tumor plus radiate the inguinal and the lymphatic channels. And after CTRT, we again reassess. So there is a small proportion of patients where the sphincter with good Kegels exercises, it can come back. So
Yes.
we give a chance for that. If not, then later again we counsel the patient for permanent colostomy, and if there's any residual disease, of course APR. So it depends on the choice of patient. But then yes, but we do go ahead with CTRT first.
I think fair enough. So the sphincter tone is not entirely lost. So give
Yeah.
a chance just in case in that patient with after the disease has regressed and with training, that patient develops sufficient sphincter control that doesn't require, is not totally incontinent. Fair enough.
Yeah, even partial, it can
Yeah, even
come back
partial.
gradually. So it's good.
Good.
Yeah.
Okay, carry on.
Discussion part. So I'll briefly talk about the anatomy of the anal canal. It is different from the rectum mainly because its embryological origin is different from the lower part of the rectum. As you know, the caudal-most point of the hindgut is called the cloaca, and the ectoderm below the cloaca is called the proctodeum. The anal canal develops from the proctodeum, and it has a completely different lymphatic drainage and blood supply from the above part of the rectal region. Hence, the lymphatic drainage of anal canal is different from a regular rectum case. And this can be divided into anal, perianal, and skin cancer. Perianal cancers are tumors which are within 5 centimeter range of the anal canal. So the vascular and lymphatic supply, if you see, is mainly determined by the pectinate line. That pectinate line differentiates between the origin from the hindgut as well as the proctodeum. So the lymphatic drainage chain differs based on the dentate line. So the above the pectinate line, the arterial and venous superior rectal artery and vein, which is along with the lower rectum, and lymph nodes above the line is superior hemorrhoidal and perirectal lymph nodes, and below the pectinate line is the inferior rectal artery, inferior rectal system, and the inguinal group of lymph nodes. Now, epidermis, it is a relatively rare tumor, forms around 4% of lower GI tract tumors in age groups more than 50, median age is around 60. It is increased incidence is seen in bachelors and white males. There is a relation to homosexuality and age, but it is not an age-defining illness, and there is relatively larger female predominance. The probable causative factors are HPV infection, 16 more than 18, HIV, multiple sexual partners, receptive anal intercourse, history of vulvar vaginal or cervical cancers. According to American Society for Colon and Rectal Factors, others are age, smoking, and immunosuppression. Basically, any immunosuppressed condition where the cell-mediated immunity is lowered, these patients are unable to clear the HPV infection, which could be the causative factor for such tumors. So staging, briefly, as I had discussed the AGCC T and NM staging, all we can remember, once a node is positive, the tumor becomes stage 3, and this T and N1 sequence. So management guidelines. I would first come show you the slide once and then go back to the history of the how treatment has evolved.
Well,
And
before you
yes, sir.
start your management guidelines, if you have to tell me one name associated with who revolutionized the management of anal cancer, what is that name?
Sir, Negro, Mr. Dr. Negro.
Okay, carry on.
So, as per the NCCN 2021 guidelines, the primary treatment for anal canal cancer is CTRT. In terms of the workup, you need to have a digital rectal examination.
Music has to be muted.
Need to have a digital rectal examination and inguinal lymph node evaluation. If the lymph nodes are suspicious on clinical, you can consider for a biopsy or FNAC. A CT pelvis or a CT pelvis or an MRI can be done. A PET CT can also be considered in such patients. An anoscopy or proctoscopy, which can be done in the OPD. HIV test is important, and for gynecological patients, gynae examination also need to screen for cervical cancers. And a fertility discussion needs to be done with the patient prior to the treatment. We will revisit this slide again later. So looking at the history, prior to the mid-70s, the standard of treatment for anal canal cancer was surgery, which was abdominoperineal resection, which was associated with the permanent colostomy bag and long-term morbidity complaints of urinary and sexual dysfunction. So when we compare upfront surgery versus radiotherapy, it starts off with Norman Negro and his radiation oncologist Gunter Seidel, who had shown that with the use of preoperative radiation and chemotherapy in anal canal squamous cell, they had showed it initially with 3 patients, which was then later progressed, done with 28 patients and was updated by Boroka. He showed that these patients, majority of these patients had clinical response and did not require surgery. So they had used radiation along with chemotherapy, and they assessed response at 4 to 6 weeks and then decided whether the patient required surgery or did not require surgery. So at 6 weeks, they saw that 57% of the patients had response and residual disease was present in 43%. And patients with residual disease had undergone surgery, and it was shown that in that patients of residual disease, 42 had residual disease and pathological complete response was seen in 58%. So they concluded from that study that chemotherapy and radiotherapy is enough. It will not require repair if the lesion disappears. But if the residual disease is present, we can go ahead and do a surgery should be reserved in these cases for patients who don't respond to treatment. So now the next question is, since we have established radiotherapy is the standard of care, they checked the role of chemotherapy. So I'll be discussing only one trial, mainly the ACT-1 trial, which was done by the UK Cancer Research Group, Anal Cancer Trial Working Group, where they treated patients with radiotherapy along with 5-FU and chemotherapy. Radiotherapy alone was the RT chemotherapy. They showed that along the 13-year follow-up data showed that CTRT is superior to RT alone in terms of local regional control was better, the colostomy-free survival was better, and overall survival was also better. So coming back again to the treatment guidelines, first our National Cancer Grid guidelines, which are based on which can be practiced at any center. There's a digital rectal examination, which I told, a biopsy, a CT abdomen pelvis, and a chest X-ray for a metastatic workup, and an FNAC nodes, and HIV testing and CD4 count since it's associated with low immunosuppression. T1, T2, T3, T4, and N plus tumors and metastatic disease. So we treat table A, which you can see T1, T2. The table A is 5-FU or capecitabine, 5-fluorouracil or capecitabine plus MMC and radiation, 45 to 50 gray, plus a boost can be given for T2 lesions. For T3, T4 and N plus lesion, 45 to 50 gray followed by a boost of 9 to 14 gray can be given. And after completed treatment, we assess the response at 8 to 12 weeks. If there is local progression, persistent, complete response, we can follow up and keep the patient on clinical follow-up every 3 monthly. And local progression, if the patient is progressing, then you can consider for surgery. If there's still persistent disease at 8 to 12 weeks, we can still observe the patient and check if there's any progression or regression of tumor. So coming back, the same, which is a more advanced with NCCN guideline, which shows definitive CTRT is the management with mitomycin C and 5-fluorouracil. Now looking at the chemotherapy protocol, the preferred regimen is 5-FU plus mitomycin C plus RT. The other option, which is capecitabine plus mitomycin C plus RT. 5-FU is an infusion drug given on day 1 to day 4 and day 29 to day 32, 1000 mg per meter square. And mitomycin is given between 10 to 12 mg per meter square on day 1 and day 29. If the other option is capecitabine, the advantage of it being it's an oral drug which is taken Monday to Friday on each day of RT, and mitomycin C is given on day 1 as a bolus dose. So now coming back to the radiotherapy dose fractionation technique and the importance of the overall treatment time. So RTOG 0529, which was a dose painting IMRT study where they gave differential doses and tumor volumes based on the tumor size and nodals. For T2N0, gave 42 gray for the prophylactic nodal irradiation with 50.4 gray to the primary, and T3, T4, N0 to N3, 45 gray elective node and 50.4 gray to less than 3 centimeter node, or more than 54 gray for more than 3 centimeter metastatic node, and 54 gray was given to the anal canal. This trial is important because it showed that by using IMRT, we are able to reduce the grade 2 toxicities of treatment by at least 15% as compared to your conventional technique. Hence, currently IMRT is preferred for treating anal canal cancer. So there's another institutional study. They showed impact of radiation on loco-regional control. We saw that patients who received more than 60 gray had more chances of grade 2 GI toxicities, and late GI toxicities and geotoxicity also more in patients who received more than 60 gray. And doses more than 64 gray had higher chances of ulceration. So our institute, we practice a phase 1 of 45 and 25 with a sequence integrated boost to gross nodes to 57 to 60 gray, and phase 2 of 15 gray in 6 fractions to the primary nodes. And for brachytherapy, for smaller lesions can be considered such as T2, which have good response, but for circumferential lesions, the diagnosis or and for non-circumferential, if the circumferential lesion, brachytherapy is avoided. So if you look at the conventional radiotherapy.
So again, just 1 second. So the 3rd year resident exam batch, Prithvijit, he said when there's circumferential involvement, we avoid brachytherapy. So why is that?
Because sir, brachytherapy will affect the sphincter function, because after placing the interstitial brachytherapy,
it may affect sphincter function. What else could be the problem? So one, you could have incontinence. What are the other problem with high dose radiation for anal cancer?
Fistula may form between the skin and
necrosis could happen in fistula. Okay.
Even the quality of sphincter may not be good if you give higher dose. The sphincter also, the quality suffers. So now more focus is going on de-escalation of these doses, and and the doses should be decided as per the HPV status. So HPV 16 positive patients are more radiosensitive, so we can de-escalate the dose and according to the response. So anything between 50 gray to 60 gray, depending on the response, should be decided.
So you remember Negro that, how initially with quite low doses he could get that response, and now we know the reason, because these are all HPV related cancers, and we know that, for oropharyngeal cancer it has been well popularized, but the same applied in anal cancer. That's why he could see such wonderful response with doses what he thought was just preoperative doses. Okay, carry on.
So look at the conventional borders. portals, anterior posterior parallel opposed fields can be done. The phase 1 upper border is kept at the lumbosacral junctions. Phase 2, which is include the common iliac, presacral nodes, lower rectosigmoid nodes along with that. And when you bring to phase 2, you bring the superior border inferiorly, such that the upper borders move to lower end of the sacroiliac joint, so that only you treat the perirectal, lower presacral, and internal iliac nodes. And finally, for the phase 3, which is out here, we ensure that we only treating the primary tumor GTV with a 9 gray and 5 fraction of 14.4 and 8 fraction. So when you compare the lateral group of groin nodes, they have to be treated with a separate anterior field. Now, when we're giving such the similar thing, shrinking field technique, which was done, the RTOG, where you can see that the AP portal and the PA portal have different dimensions. Superiorly L5 S1 junction and laterally lateral to the femoral head in phase 1 portal, inferiorly 2.5 centimeters from the perineum or below the Gauche disease. But the posterior portals is narrowed so as to protect the femoral heads, but lateral borders reduced to the medial to the femoral head. Similarly, similarly as I described in the clinical diagram, we reduce the superior border in the AP portal will shrunk to spare the femoral heads, as well as the lateral borders are reduced. And in phase 3, again, you have to only boost the tumor volume, only the primary tumor. Now, there were multiple techniques which were done to check for irradiation of groin nodes. This was mainly done for valval tumors and for post-op tumors where we needed to drain the groin nodes. So there was this photon through and through, photon thunderbird with skin match, thunderbird technique, electron thunderbird, and intensity modulator. This paper was published in 2004. If you look at it, one was the photon technique, in which we use an anterior posterior field, but the fields are of same size in the photon through and through technique. But what we did is the posterior uses a higher energy field and anterior use a lower energy field, such that and you preferentially weight the anterior field so that the prescribed dose is prescribed at the most posterior aspect of the femoral vessels, limiting the femoral dose as much as possible. The other common, more popular one is the Thunderbird technique. It is known as the Thunderbird as it produces an isodose distribution similar to the birds with outstretched wing, like birds of thunder. As you can see, this isodose distribution, it includes the primary tumor site as well as the groin nodes. So in this Thunderbird technique, what they used is the anterior and the posterior fields were of different dimensions. Okay, whereas in the through and through field, photon through and through field technique, the anterior and posterior fields were the same direction. But here the posterior fields were narrowed so as to protect the femoral heads, as you can see in this clinical diagram, so that the dose does not exit through the femur, but the weightage was kept the same. So they were mainly, and along with that, we added an additional anterior field to cover the lateral group of lymph nodes, a lateral group of groin nodes, in which this can be delivered through a photon or an electron. So it was a photon thunderbird with skin, so which could be done with a skin match or with a deep match, and third was the electron deep thunderbird. So that study had showed that the photon thunderbird with skin match, where they matched the fields based on skin, was unacceptable because there was 30% cold in the groin region. The electron thunderbird was ideal for thin patients, where we use an anterior and an electron field. But for thin patients, where we can depth of the inguinal vessels was less than 3 centimeters. In average size patients, photon through and through and photon thunderbird were the treatment of choice if you had to treat them with 3D CRT conversion techniques. So they showed that the risk of fracture to the femoral head is approximately 11% at 5 years using photon through and through technique. Now, impact of the overall treatment time and role of IMRT in anal canal management. So, impact of radiation.
You are not going to discuss 3D CRT IMRT?
IMRT I have kept, no ma'am, just the dose constraints are.
Sorry, you've discussed all these rubbish techniques which we never use, and you've not discussed anything what we use. What is the problem? IMRT is the only indication in actually in GI cancers, and it is a must. You should have gone through the nodal stations, everything, when to include inguinal nodes, all that, in a snapshot.
I showed in the.
I think he was fascinated by Thunderbird, and
which we never use. We never use. It's such a horrible this thing dose distribution when we see in this modern planning techniques. So we
So,
never, it is only for historical
yeah,
reasons, those
that is how
Thunderbird
it
and
used to be done. Now it is the other thing, different ways of giving boost. One was, say, implant, okay, interstitial implant. What are the other ways? One you showed. What are the other ways of giving boost to the residual tumor in the anal canal? So one situation is where it's only perianal. See, there is also perianal cancer. They are not so predominantly perianal region with little extension into anal canal, just say 1 centimeter. Or other is predominantly anal canal with no or little extension to perianal. So if you have to give a boost beyond 45 gray, what are the different ways of giving boost? So Prithvijit, you tell that answer. It may or may not be in your slide. Please tell us.
Sir, I can do it with obviously I can do it with photon, or I can do it with
Photon
electron
means,
with
oh, photons, of course. We have only photons and electrons. These are only two things we have. We're not talking of protons right now. So how with photons? APPA fields, two posterior oblique fields, planar fields, non-coplanar fields. Please answer that. So for a perianal, predominantly perianal, disease with little extension into the anal canal. So what will be the position? Will it be in the same position as you were giving your treating pelvis, or in a different position? Technique? Are you aware of it? You may not be aware of it. You may not have seen it, but at least you should be aware of it. Everything. See,
And the
sir,
treatment portals for T2N plus or T3N plus are different than T2N0. You have not said anything, Prithvijit. I'm very disappointed. So in the node negative disease, you can lower down your borders. You don't have to go to L5, S1. You can go to the SI joints lower border. Okay, so therefore you can reduce the morbidities when you have.
hematological and acute bowel toxicity. You can reduce.
Yes. So that you can reduce the borders, as well as when you have, like how Sir said, perianal skin. So there are different ways of treating the perianal skin. You can boost, you can have a sequential boost using bolus and all, or you can use a mold technique, which we have used in couple of patients. You can make a customized mold, surface mold, and and give a boost just to the perianal skin and just going inside the anal canal. So there are different techniques.
That is not
CBRT.
very easy to treat when it is predominantly perianal region. I mean, some centers have also used a perineal port. Okay, when the couch is tilted, rotated by 90 degrees, we also used to treat in few patients. So there are various ways. So you have to individualize. You have to see that it requires very meticulous planning, clinical evaluation, and then see what is feasible. So it is not like CS cervix standard fields and this thing. So anal cancers, you have to individualize the portal. I think just let us finish your slides and whatever questions we have, we'll ask. Please.
So, the impact of overall treatment time is important in squamous cell carcinoma. And we notice that if there's missed RT days more than 3, it is associated with poor overall survival in patients. Also, presence of more than missed 2 fractions over a 30 fraction period. They showed that there's a treatment. The main reason for missed fraction were due to treatment breaks due to toxicity. This showed us
Due to
that
skin toxicity, mostly skin toxicity when you use large APP fields. Okay, so that's why IMRT role comes into play.
this study, along with this, show that the role of IMRT came in, where reducing by improve survival and reducing treatment time, because our toxicities are much lesser. We're able to reduce our treatment time, showing that IMRT can improve overall survival in anal canal patients. So the 5-year overall survival with IMRT is much better, since they were reduced risk of a long-term treatment time. So the IMRT dose constraints taken from RTOG 0529, which is been published also, which is published in NCCN 21, were given as priority number was given to small bowels, then to the femoral heads, then to the iliac crest, external genitalia, and the large bowels. So the follow-up surveillance, one thing, After completion of treatment, inguinal nodal palpation every 3 to 6 monthly for 5 years. CT abdominal pelvis can be done in case of annually for 3 yearly, and DRE every 6 monthly. The next question comes is, how long can we follow up a patient without intervention who have not achieved a complete clinical response? As per the Act 2 post hoc analysis, patients with appropriate follow-up have not achieved a complete clinical response with persistent anal cancer up to 6 months following completion of radiotherapy can be followed up to 6 months as long as there is no evidence of progressive of disease. Persistent disease may continue to regress even at 26 weeks from start of treatment, avoiding unnecessary surgery in late responders. So the take-home message is anal canal SCC is a relatively rare tumor with female predominance and commonly associated with immunosuppressed conditions. Current standard of care is definitive radiotherapy along with concurrent chemotherapy with surgery reserved for non-responders and progressive disease. IMRT is the preferred modality of delivering radiotherapy due to reduced toxicity, which leads to lesser treatment breaks.
So, Shaktivel, you had your GI posting or not as yet?
Yes, sir. I had
your GI posting. So, you said female preponderance in Tata Hospital or in other Indian centers. Do you see female preponderance of anal cancers?
So it's relatively more seen in males in India.
More.
What I noticed in my post.
So you have to say that, in the Western literature, it is described, all the treatment has been described for. So and how is the anal cancers described typically in elderly women in the West? Anal canal cancer, is it different from what you see in the clinic in India and other tropical countries? How is it different? Is it same or it's of any different kinds?
Sir, in India, it's more seen like a cauliflower-like growth protruding from the anal.
So in the Western literature, it's a more of female preponderance, elderly women, and perianal involvement is much more common, either completely perianal or predominantly perianal involvement. So it's a different kind of anal cancers that we see. So Reena, how many patients you see which are exclusively perianal or predominantly perianal? We see very few such cases.
Yeah, R is mostly involving the anal canal, a very few, like 1 to 2 centimeter of the perianal skin. So predominantly in perianal, we would see maybe 6 or 7 in a year.
Yeah.
Not more than that.
Okay. So, and now what is, so someone has asked, how safe is it to go up to 60 gray and beyond if there is significant circumferential involvement of the disease? Circumferential amount of lower rectum up to 5 centimeters from anal verge. So Dr. Haridas Nair has asked this. How safe is it to go up to 60 gray and beyond if there is significant circumferential involvement of lower rectum, that is up to 5 centimeters from anal verge?
So first assessment we do at 45 gray, where we get a fair idea whether like how the tumor is responding, and we also take cognizance of the HPV 16 status. And if the response is kind of poor, and if it is not, if it's a relatively radio-resistant tumor, then yes, we go up to 60 gray. So after 45 gray, we can give 15 gray in a slightly hypofractionated manner. So safe means first we have to control the disease, then we have to look at the safety. So like up to 60 gray, yes, we do go 15 gray in 6 fractions.
So Dr. Haridas Nair, I don't know. So just to add, so rectal cancer has taken a lot from what we found in anal cancers. From what we learned from anal cancers, that has been, I think Dr. Reena, she will talk about it. I mean, she's very passionate about it. So we are trying to extrapolate the same thing for rectal cancer. So just rectum is involved doesn't mean that, it is all gone. Is that correct, Reena?
Yeah. So rectum involvement of rectal cancer is quite common, but it does not, the treatment has to be means radical treatment. Yeah. And primarily cancers of the squamous cancers of rectum.
A lot of people feel that if rectum is involved, then we should have surgical treatment. That is, I think.
No. In fact, we go to the other extremes. We do see few, once in a year or twice in a year, we see squamous carcinomas of rectum, exclusively rectum, like starting 5 centimeter and beyond. And then again, we give them radical CTRT because it is squamous and it is a radiosensitive tumor. And surgery is
Sorry,
kept only for salvage.
there was no discussion last week and today also. Papillon technique, none of them mentioned that. Would you both for rectum and anal cancer just summarize that Papillon's technique for that, because no one even mentioned the name, I think.
So Papillon technique, he used contact X-rays, 50 kV X-rays for the residual tumor. And I think he gave 30 gray in 10 fractions. Yeah, 30 gray in 10 fractions.
So it's a very
And
superficial residual tumors, and this is Papillon where L is silent. It's a French name. Okay.
yeah,
So it's
yeah. So it was like an intrarectal
contact.
applicator that times. So it was a technique, but it again he observed that it was a complete response when we give boost through this. It is a contact X-ray technique.
How you are giving so surface? So you're talking only interstitial brachy. What are the other brachy that you use, Rima? Just can you just mention?
Yeah, so we can use surface brachytherapy where only the disease is limited to mucosa or just some mucosal spread. So we can at TMH we have Dr. Shivasto had designed this SIVA applicator, which is meant mainly for vaginal surface intravaginal applicator, which we are using for anorectal also. So the advantages, if it is less than of the circumference is involved, you can safely spare the opposite mucosal wall. And because if you give EBRT boost, then you give the entire circumference. So again, it may hamper the sphincter. So this you can give a very selective boost to the residual tumor by this SIVA applicator. It is a multi-channel surface applicator.
Okay, I think thank you. Any other point, any other nuggets you would want to share, Reena or anyone else who's there? JP is there. JP, you want to say something about some aspect of rectal cancer? And you all are fortunate you haven't done dressings for patients who have been treated with rectal cancer, severe acute skin toxicity with the scrotums, completely peeled off like boiled potatoes, and the groin, this thing. It used to take us months as ward resident when we had a patient admitted with, severe acute skin toxicity. And I think modern day residents would just never see those kind of patients. Reena, I hope you remember this.
Yeah, I have seen, and we have treated. We used to treat
It was a
OPPs, ATP on cobalt, and we used to land up with these toxicities. And in fact, in our parades, where it was written that the standard treatment of anal canal was 36 gray, and then we had to give a break, a planned break of 45 days. So planned break was advised because on those era, it would take so much time for the skin to heal. So planned break could be up to 6 weeks.
Yeah.
So now we know it is detrimental, but then because of the technology, we didn't have a choice and we had to give a break.
The URTC trial also, there was a planned break of 6 weeks and then they gave the boost.
Yes. So in our Perez, the standard technique was planned break of 6 weeks, which doesn't exist anymore. Okay. So this is a historical value.
Okay. Thank you, everyone. Thank you very much. Okay. Bye.
Thank you.
Okay. Bye-bye.